All right, let's look at this first pelvis here. This is an AP pelvis, and whoever would like to take a go at that, can you tell me what's the repeatable, I won't just say positioning, but what's the repeatable errors you see are needed on that x-ray specifically? We got some things going on here. You might point those out to us. Look very closely. What would you say is the most obvious thing wrong with that right off the bat?
There's no internal rotation.
Very good. How can you tell that, Jonathan? What's the indication of that?
The lesser trochanters are more prominent.
Yeah, so basically what he's saying, if you couldn't hear, if you look down here at the anatomy, guys, one indication that this is positioned incorrectly is we can really see these lesser trochanters in complete full profile here. We don't want this. This tells us that patient's feet are relaxed to the sides. They weren't turned internally the correct way. If they were turned internally correctly, completely hidden if possible. It says that we have an internal rotation. My back. I swear, guys. I swear. Next meeting, I'm going to make another pitch for Zoom again. I can't. This WebEx is driving me insane. I'm getting worse and worse. Okay, as I was saying, guys, just make sure you look closely at this anatomy on these AP pelvises. If you see a very prominent lesser trochanter in profile here, that's a key indication those feet were not internally turned correctly in the medial direction. Also, we don't have our greater trochanters in true profile. That's another indication. So that's one of the major positioning errors we can see on that x-ray. But what else is wrong with that x-ray? Did anyone point out another error that we see? Not necessarily just positioning related. Anything else? It's not centered. You're correct. Very good. It's not centered. If we look at this x-ray, it is a crosswise 14 by 17. Center of the cassette is approximately right here. We can see that pelvis is shifted way too far to the left. We want that to be nice and in the direct center of that radiograph so we have a nice equal distance on both sides. So the two major issues with this radiograph would be the feet were not positioned correctly, they weren't rotated medially, and the patient was not centered correctly to the film in the horizontal direction, left and right directions. It's pretty decent on the vertical aspect. They did put that light about 2 inches above the crest, which is what we want to see. Or approximately midway between as is and acetabulum down here. So about right here is where we're centered. That's very close to being correct. A little bit off, but very close. Mostly we're not centered in the left and right direction here. So let's go to the next one here. Okay, first off, what kind of hip projection? Well, the answer's right there. It's not even unilateral. That's a misprint. I'm sorry. This should not say unilateral frog leg. That should say AP pelvis. I didn't fix that. So forget what this is asking right here, but what's the repeatable positioning error that we can see in this radiograph here, guys? What's the major error that you can notice? It's very subtle. Very, very subtle.
Maybe rotation.
So you said rotation, guys. What's the indication that we have some rotation going on there?
Maybe the ala, maybe.
Look at the ala. This ala is
also, yeah, it's a little bit bigger.
The left ala is a little bit bigger. Very, very slight. Very slight. What else could we look at for an indication on rotation? Spine looks a bit curved. You're correct. That means that patient's probably shifted their weight on their hips when they were laying flat on that table. He's noticing this right here. The spine is a little bit rotated. What else? What would be it's not very, thank you, the foramen. Now, it's not extremely evident on this x-ray. It's very subtle. There is a fracture there. It's kind of messing up as well. If you look at the comparison of these two obturator foramina, the one on the left is slightly smaller than the one on the right. So you want to always look at the ala, or the wings of the pelvis, the obturator foramina, and even, yes, the spine. Check that rotation on those pelvis x-rays. But what else? Is there anything else that we see going on in that radiograph? Anything that looks odd to you? Or anything that is an indication of a positioning error?
Same thing with the trochanters, right?
Same as the first one, yes. We still got a little bit too much of these lesser trochanters showing in profile. That tells us that they did not rotate those feet all the way in medially, positioning that x-ray. We only want the very little tip of those trochanters to be showing, just barely. These are very, very much in full profile. Once again, that tells us they had those feet relaxed instead of turned inward. Now, why am I repeating that a lot? Because that's probably the biggest error that we see on pelvis x-rays. So when you comp on this, one thing, whether it's me, Mr. Fong, Ms. Lar, whoever you go to, we're going to look to those lesser trochanters and see if they're mostly obscured, because one thing that sticks out to us the most is those lesser trochanters in profile, which indicates that you did not turn those feet in properly. So make sure you get those feet turned very, very prominently, at least 15 degrees, immediately touching those toes together to cover up that lesser trochanter as much as possible. And this is an AP hip. AP pelvis. Once again, guys, AP pelvis. Let's see. Let's look at this bilateral frog leg here. Let's see. Let's name at least one positioning error here. Can anyone see anything going on? What's funny about this X-ray? What's going on? I think we got some major issues going on here.
The hand.
Say it again, Asias.
Maybe. I'm seeing the hand. Maybe take like on the left.
You're very good eye. Did everyone else catch that? He's saying he sees a hand in there. You guys see the hand? Right here. Grabbing their leg. That's a major issue. We never want to have that happen, because we're exposing that hand and arm for no reason, but it's also obscuring anatomy. What else is going on? Anything else?
It looks like there's a fidget spinner.
Looks like there's a what?
Fidget spinner.
Oh, fidget spinner. It does look like a fidget spinner. That's true. That's actually a type of shield. It's a pediatric shield. Sometimes they look like that. But it does kind of look like a fidget spinner. You're correct. So on that subject, Aurora, since you brought it up, would you say that fidget spinner shield is placed correctly or incorrectly?
It's incorrectly.
And why is it incorrect?
I feel like it should be more in the middle, and it's more to the side. I don't know.
You're correct, because look, we're only covering up a small part of this patient's genitals right here, just right here. We want that to be over the entire genital area, otherwise it's doing no good. They're still being exposed. So definitely want to move that more central, make sure we're covering up the gonads properly. What else is going on? Anything else in this x-ray? Anything on? Anything off?
The legs aren't equally abducted.
Say it again, Jonathan. I'm sorry.
The legs, they're not equally abducted.
Yeah, the legs are a little off. It looks like they could have. It looks like they got one leg extended more than the other. They're not exactly even, but not enough that we repeat on that positioning error, because we still got the femurs in a lateral position. But you are right that they are slightly off. That is correct.
Yeah, the center as well is off.
Centering is very off. Do we need all this femur on here? Look how far up this pelvis is. Look at all this space down here. We don't need all that. We can center it down a little bit further. Good, good. How about the quality of the x-ray? You guys think it's a pretty good quality x-ray as far as the the contrast and the density. A little bit muddy, right? So this x-ray was not penetrated properly. They probably did not use a high enough technique on this patient. Also, it's a good point of what bad centering does to you. Just think about it. I want you to look at this for a second. This is why centering plays such a huge role in what we do. Central ray is penetrating right here, essentially. It should be penetrating more so up here in the thicker area of the bone. We're penetrating through just clear space here, essentially. So we're not getting ample penetration, attenuation of the bones. Therefore, it's bringing that quality way down, making it very muddy and grayed out, contrast resolution's off. It did not get ample penetration. Also, the techniques are probably a little off as well, but the main issue, I would say, based on what I'm looking at, is the centering is so off, they aren't getting ample penetration on that x-ray. Now let's look at this x-ray a little bit closer. Do we see anything as far as pathologies on this x-ray? Do we see any fractures, any dislocations, anything going on?
Maybe fracture.
You think there's a fracture, Asias?
Yeah, and maybe on the left femur. Maybe.
Over here?
No. I'm talking about left.
So on the right?
Right, maybe.
You talking about this right here? How about down here? Is that normal or is that a pathology? I think that's normal or pathology? What do you think?
Pathology.
Thinking it's pathology? Okay. Well, actually, I'm just trolling you guys. This is actually, did y'all guys catch this as a pediatric pelvis? It's a small child. So I did that on purpose because I want you to see how different a pediatric pelvis actually looks, because a lot of people will mistake it for pathologies. I mean, the first one we can see, most of you probably remember this. You can see those clear growth plates right there on the femoral neck. That's totally normal. But a lot of people will look at the rami of the pelvis and think those little splits are pathology. That's actually completely normal. When a child's developing, when a child is developing, there's growth plates right there on the pelvis as well, between the superior and inferior rami. So one thing to keep in mind if you ever get a child for a pelvis, that's totally normal there, to see that little split going on, because those are fusing together. Also, you can see it right here as well. See where the ilium and the ischium have it combined? Another gap right there. More of those growth plates. Those growth plates are in more places than just the wrist and the ankles or tops of the femurs like we're used to seeing. They're all over the body as that child's developing. Good eyes, guys. Good eyes. Good eyes. Good. Good. All right, let's move on here. Let's see. Let's do some questions here before we do our practice quiz. So for an AP pelvis projection, and you can put it in the chat or say it out loud, whichever you prefer, where is that central ray centered? See some C's. I see some C's. Good. Yes. And that is midway between the as-is and symphysis pubis. That is correct. Pay close attention to that. Seems simple, but people make a mistake on that quite often. They will often choose level of iliac crest. They'll often choose level of as-is. And don't mix it up with the technique I taught you guys where I said you put the light 2 inches above the crest. That's correct, but that's not the actual central ray location. Technical central ray location for an AP pelvis will be midway between as-is and symphysis pubis. Because it is kind of hard to palpate for and look for, you can use that light method I taught you guys last week. All right, to minimize distortion of the femoral neck for an AP bilateral frog-leg projection, the lower limbs should be abducted how many degrees? see some B's. I see some B's. I see some C's. So the correct answer is actually going to be C. It is 45 degrees for that AP bilateral frog leg projection. Watch those angles on the legs. They do change a bit between different types of x-rays we went over in this chapter. Make sure you're reviewing those. It's an easy thing to mix up. So for the AP bilateral frog leg, we want to abduct those lower limbs 45 degrees. And the main reason we do that is to minimize distortion, femoral neck. Also to put those proximal femurs in a nice true lateral position when we're evaluating those hips bilaterally. All right, here's one that people get mixed up a lot, guys. Look very closely here. What type of CR angle is required for an AP axial outlet projection for a male patient? You do remember it does change between male and female. See some A's. See a bunch of A's. See a bunch of A's, good, and you are all correct. It is a 20 to 35 degrees cephalic, and for females, it's going to be answer B, 30 to 45 cephalic. Be very careful on that, guys. If you put a big star on that, you will see a question on that. Make sure you know the difference of those CR angulations between male and female for that outlet projection. How is the cassette aligned for an axiolateral Denius-Miller method projection? A little bit different wording here. We're not talking about the central ray. We're talking about how is the cassette aligned? In other words, where's the center of that cassette basically going to be? Be careful. So when we're thinking about it again, when we're aligning a cassette, where are we putting the center of that cassette? Because our central ray needs to be in the center of the cassette. Where would the center of that cassette be aligned to? Think about it. Okay, I'm seeing every answer there listed. So let's think about it. I did this on purpose, guys, because this is a big mistake people make. So the answer to that was parallel to the femoral neck. Why? Well, the cassette will technically be parallel to the femoral neck because the center of that cassette will be in the parallel position in relation to that femoral neck. Now, where's the central ray go? Central ray also goes perpendicular to the femoral neck. Therefore, the cassette will be parallel to the femoral neck. Now, why is it not C? Because I saw a lot of C's. A lot of you probably learned in lab that you're going to put the top of that cassette close to the crest. Yes, you're putting the top of the cassette very close to the crest, but we're not actually going to be aligning our cassette to the iliac crest. The top is there, but the actual alignment is parallel to the femoral neck, so we've got to match it with the central point of where that anatomy we're wanting to view is. So the answer would be parallel to the femoral neck. If I ask where the central ray goes, it would be perpendicular to the femoral neck. Cassette's parallel to the femoral neck. CR is perpendicular to the femoral neck. Top of the cassette, essentially iliac crest, but that's not the actual alignment of that cassette. So be very careful with that point there, guys. It's an easy thing to mix up. And femoral shaft, it would not be that because we're not even interested in the femoral shaft at all in Denius-Miller. We're only interested in the hip or that proximal portion of that femur hip area. Let's see, which of the following projections is best suited for the patient with limited movement of both lower limbs to demonstrate a lateral perspective of the proximal femur? I'm seeing some B's, I'm seeing some C's. So keyword here, guys, limited movement of both lower limbs. In other words, that person's probably too injured to move those legs. That's going to be your key point there. This person's probably way too injured to move those legs. So that answer is going to be D. So a lot of you put B. I can see why you did, but think about it. Patient that can't move those legs, because they're injured, what's the key aspect of Denilius Miller? We're taking the unaffected leg and moving it all the way. If their legs are injured and they have very limited movement, we can do an alternative to Denilius Miller. The alternative to Denilius Miller would be that Clements Nakayama method. Only if they can't move those legs or they have very limited of those legs. So we would do Denilius Miller if we can easily move that leg out of the way. They can't, or it's very limited. We're going to opt for D, the Clements Nakayama method. Not ideal by any means, but it's an option should they not be able to move those legs properly. And that is the end of our last chapter of Rad Pro 2. Don't go anywhere. I've got some more practice questions for you guys coming up here in just a second. So we got to do our last little quizzes review here for Rad Pro 2. Some more types of questions you can expect on the test coming up.
Hey, Mr. Donahue?
Yes.
Can you go over the Clements Nakayama one, like the height position for ankles and everything? Again, I was having a hard time visualizing it.
Sure. Let me pull it back up. Okay. So one thing, if you guys remember from last week, one thing I said to make sure to not, even though you technically can do this with your tube, I would not recommend putting a CR angle of 30 to 40 degrees. The main thing that I want you to focus on this method right here is this main point. Number one, or two main points. Number one, you're going to put your CR at the femoral neck, just like a Denilius Miller. Number two, you're only going to do this as an alternative to Denilius Miller. You don't need to know all this stuff right here because this x-ray does not work very well. It's a very, very poor x-ray. So it's more of a, to put it simply, it's a think outside the box x-ray where you're going to adjust your tube accordingly just to be able to penetrate through that hip without intersecting both legs. So even though it says at 30 to 40 medial lateral, that's not going to be the case for most of your patients. You're going to have to make all these minor adjustments and really think outside the box to get that correctly. The main point I want you to know, and the main thing that they would ask you as far as a registry-related question is, what's the alternative to a Denilius Miller if the patient cannot move their legs or have limited movement of their legs? You would state modified axiolateral or Clements Nakayama method. And the CR would still be centered to the femoral neck with the cassette parallel to the femoral neck. Answer your question? Good.
Yeah, absolutely. So just however you need to angle to get it towards point at that neck.
Yeah, don't worry about that because even though Bontrager states this doesn't even work. It's not.
Okay.
It's not even relevant to that position. That's a mass guesstimation on their part right there.
Okay, sounds good. Thank you.
Okay, guys, let me go ahead and pull our practice quiz up. Just a second. Got 20 practice questions for you. There you have it, guys. Join myquiz.com with the code at the top of the screen. Join up, and we will get these practice questions rolling right along here. 2 more weeks, indeed. Blueberry. Ready for Christmas. Enter your name. Mr. Bones, Ramus, surviving on coffee. Ooh, I filled out. Yes. Right. Everyone, about another minute to get joined up here. We're getting better with the creative names. There's hope. There's hope after all. All right, guys. Well, let's get rolling along here. Let's see how you do. Read your questions very carefully. Here we go. The hip bone is composed of how many sections? That's going to be 3. And those 3 specifically are the ilium, ischium, and the pubis. Make sure you know those 3 sections look like, know where they are, of course, know them by name specifically. 3 sections of one hip bone. One hip, remember the hip has 2 bones, 2 sides, left and right. Now think of it this way as well. If I talk about the entire pelvis, it would be 6. There's 2 ilium, 2 ischium, 2 pubis. 1 hip bone, ilium, ischium, pubis. So be careful on that point. Know what they are, know what they look like, know where they're located. The fovea capitis is the most distal portion of the pelvis. True or false? And that is going to be false. That is going to be false. The fovea capitis is actually not even the pelvis at all. It's on the femur, head of the femur, that little tiny little hole at the head of the femur. The acetabulum is composed of what section of the pelvis hip? It's going to be all 3. All 3. That's called the acetabular junction, where all 3 of those sections come together. Hip joint areas. All 3. All 3. Which of the following is most distal? going to be the ischial tuberosity. Ischial tuberosity. Distal portion on that pelvis. The pelvic brim is also known as what? It's going to be the birth canal. Birth canal. Also make sure, guys, when you go back and look over that material, between the true and false pelvis. True and false pelvis. Know those points. The female pubic arch is what angle? It's going to be greater than 90 degrees. It's the wider of the two. Males will be less than 90 degrees. It's a lot sharper for a male. D is referring to what? It's going to be that ischial tuberosity. Ischial tuberosity. Specifically the left ischial tuberosity. Don't forget your left and right, guys. I is referring to what? That's going to be the acetabulum. As you guys know, acetabulum is my favorite anatomy on the pelvis. Therefore, remember one of them out of all those. Remember that acetabulum. That's an easy point for you. You can guarantee that's going to be on your test. F is referring to what? That's going to be the greater trochanter. Greater trochanter. And be careful on that. Do keep in mind on the Danelius Miller, the lesser trochanter is actually superimposed on that femoral shaft. The greater trochanter we can actually see on both sides, protruding on the sides here. But you know how to identify that on a diagram as well as an X-ray. Name the exam. I think I just told you. That's going to be, of course, a Danelius Miller, also called the axiolateral. Yeah. When rotating the foot inward for a pelvis or hip, what anatomy should be clearly in profile? going to be the greater trochanter. Greater trochanter. Remember the lesser trochanter, even though we might see it slightly, we want mostly the one we want in profile is the greater trochanter. That's why we pull those foot, and so that's why we rotate those feet medially inward. The central ray for an AP distal femur should enter where? That's going to be the mid-femoral shaft. On that distal, make sure you remember on the distal femur, we must include the knee joint. For a proximal lateral hip, what anatomy must be included? That's going to be the hip joint. Now, why did I word it that way? Off there, where it said proximal lateral hip. Do keep in mind an interchangeable name that labeled as a proximal lateral femur or a proximal lateral hip. Because technically, a proximal lateral femur is the same as a hip X-ray in retrospect. So don't mix that up. If you see it either way, they both refer to essentially the exact same exam. Proximal lateral hip, proximal lateral femur. Interchangeable terminologies. We do need the hip joint on both of those. How many degrees are the feet rotated medially for an AP pelvis? That's a really important one to remember. That's going to be 15 to 20 degrees. 15 to 20 degrees. Main point of that, once again, is to hide those lesser trochanters and put the greater trochanter through profile. What size cassette and orientation are needed for an AP pelvis? That's going to be a 14 by 17 crosswise cassette, also called landscape cassette. Another name for a unilateral frog leg hip is modified cleaves. Modified cleaves on that one, guys. Make sure you know those alternative method names to those positions. Some of them sound very similar, like Clements and cleaves. Make sure you know the difference between those. The CR for a Cornelius Miller hip must be perpendicular to what? That's going to be the femoral neck. Femoral neck. punctuation for an outlet method pelvis for a female must be? $30 to $45 cephalic for a female, $20 to $35 cephalic for a male. Make sure you know what there was. I switched it up from that last question that was on the PowerPoint. Males 20 to 35 cephalic, females 30 to 45 cephalic on that outlet view. And do remember on the inlet view uses the same exact angulation for male and female. The only time we have a difference is on the outlet view. Excuse me. An alternative to a Danilius Miller when a patient cannot move either leg would be what? That's going to be that Clements Nakayama method that we just discussed. Clements Nakayama. Good. And last question. Shielding of a female pelvis x-ray is always required. True or false? And that is going to be false. Do keep in mind for females, it is optional. Males, it's required. Females, optional. Everyone got it. Good. Good, good. Okay, so in third place we have projection junction. Second place we have dot dot, and first we have Jonathan Negri. Who was projection junction as Naomi? And who was dot dot?
Me.
Who's me? Oh, okay, Sharon. Good job. Good job. Good job, guys. All right, I will send that practice quiz to you guys in your email so you can practice while you're studying. Go ahead and take this off here. Okay, with that being said, so do remember on Wednesday is going to be the image review test. Friday is going to be the multiple choice test. For the image review test, you can expect the same number we've usually been having between 4 and 5 x-rays. Maybe a bonus, maybe not a bonus. I haven't decided yet. But same format. Don't forget your left and right, being specific to the parts. Same way we've done it every single time thus far. And of course, the Friday test will be the multiple choice test, 50 questions. Are there any questions you guys have about what to expect or in the material for Wednesday and Friday?
If you have a second, can we look at the practice images that you sent? The GK
method? Did you say the images I sent over the break?
Yeah,
what you said?
The GK ones specifically.
Yes.
My question was, I was looking at them, and like one of them says LPO, and one of them says RPO. And then, but like still like the LPO, it's listed as the right side. It has the R marker. It's the right side that's up.
Hang on one second here, John. Let me get it pulled up. Your audio is a little choppy, but I think I know what you're asking. Hang on. No, it's not your fault. We'll blame it on WebEx.
I agree.
So, are you asking why did I label this as LPO, even though it has a right marker?
Yeah, so looking at this one, so I'm assuming that means the right side is up. Is that correct?
You are correct. You are correct. So yes, it is marked as a right. The right side is up, but technically, if that right side is up, that position of that patient is still going to be an LPO because the left side's down.
Right. Yeah.
And then conversely, same on this side here. That's going to be an RPO because even though the left side's up and labeled, the right side is the one down. Therefore, it's RPO. Both considered Jude views because they're oblique pelvis X-rays.
Okay. Well, when I was looking at those, so both sides are the upside that I'm looking at, right?
Yes.
They just look a little different. That's why I just was.
Yeah. This patient's obliqued a little more on this X-ray versus this patient. They're a little more relaxed, but both sides are elevated on the X-rays.
Okay, I just wanted to make sure I was reading that right.
Yeah.
That both the side.
Main thing I would focus on for those X-rays is when you see an oblique pelvis, you need to default to that's a Jude view. That's what I want you to focus on. And the reason we would do it would be to better visualize the acetabulum.
Right. Okay. That clarifies. Thank you.
Yeah, no problem. Any other questions, guys? So my dog's flipping out downstairs. I don't know if I hear them barking, but they're going crazy down there. Any other questions, guys? Well, in that case, let's go ahead and go on to the next chapter. We're going to go to let's see, I think we're starting on the C-spine. We're going to go ahead and jump ahead to next semester because we don't want to get behind. So we can start our C-spine right away. I mean, I can see you're just dying to get into it. I mean, I can read faces quite well. I mean, am I misinterpreting this? Because you guys look really, really, really excited to go to C-spine. I'm telling you. I mean, Jessie, look at her. She's saying, I mean, she's like real enthusiastic. Yeah. No, that'll be it, guys. If there's no more questions, we're going to end early today. Study hard. If you have more questions as you're studying, you know how to reach me. Please let me know. I'll be glad to clarify anything for you. Let me know, and I will answer that for you. Other than that, you guys have an awesome afternoon, awesome evening. Enjoy clinic tomorrow, and I will see you guys bright and early on Wednesday. Take care and goodbye.